So we're going to start with a case. So I want you to imagine that you've had a call from delivery suite. This lady who's just arrived at 22 weeks and 1 day with premature rupture of membranes and contractions. She's got a cervical suture in situ, which they're planning to remove. Please, can you come and talk to her? So I'm going to start with a question about risk. What risk category does this fall into? If you hadn't managed to join the Slido before, there's the QR code and the Slido code again. I'll show the responses in a second. I can see in the top corner how many people have managed to make it work. I know there's 67 people online. We've had about 20 responses. If we can get up a little bit higher, I'll show you the answer. Encourage people to answer before they see what other people have said. We can get to 40 responses and I'll show you the answers. If you are still working on it, don't worry, the QR code and the opportunities to take part, and indeed this poll, will still be there if you don't manage before I move on. Okay, let me move on.
Dominic, okay. There's a question, just could you please just share the scenario again? Sorry to interrupt you.
Of course. So the scenario was a 22 plus 1 week lady with premature rupture of the membranes, contractions, cervical suture, which we'll need to remove. Please, can you come and talk to her? So most of you have said that this is extremely high risk. Some have said I need more information to decide. A couple of people have said high risk. Interestingly, nobody said they didn't know. So it suggests that most of you know what this is all about. Another question, perhaps more practical. So which of these options would you give to this woman in talking to her? Do everything, provide survival-focused care, see what the baby looks like and decide at the time, comfort-focused care, you need more information, or you don't know. And I think you can give more than one option. You should be able to give more than one option with this slide. At least that was my plan, but apologies if I didn't set it up properly. Okay, we've had 38 responses. So there, a number of you say you need more information. 50% have said comfort-focused care. It should be care, not case. Apologies. Some have said see what the baby looks like. Some have said survival-focused care. Somebody said do everything, and nobody said they don't know. You're a very confident bunch joining here today. Good. Last question for now. I'm going to have more questions, don't worry, very soon. How comfortable would you be providing counselling in this situation? Remember, this is a lady who's 22 weeks and 1 day, just come into the delivery suite, contractions, ruptured membranes. She's got a suture in which is going to be removed. You've been asked to counsel her. Okay, and a third of you said you were comfortable. A third said you were uncomfortable. A quarter said you were neither comfortable nor uncomfortable. Okay, very good. We may come back to this question later at the end of the talk. So the aim of this session over the next hour and a bit is to talk about how we approach extremely high-risk preterm antenatal counselling. We're going to start with talking about what we mean by extremely high risk. We'll talk specifically about extremely high-risk counselling and then some challenging questions and scenarios. I'm hoping or suspecting that many of you will have been to the other part of this webinar, which was focused on other risk scenarios. I'm not going to focus on them very much, with one exception later in the talk, in the challenging questions scenario section. So what do we mean by extremely high? Well, I've got some more questions for you. Which of the following activities would you class as extremely high risk? You should be able to answer more than one of these. I didn't give you the option of none of them, so apologies. That should have been on my list. I'll try and correct that for the next time I run this scenario. Good. So there's a bit of agreement that climbing Mount Everest, or free climbing, which is mountain climbing without a rope, is extremely high risk. Other views about these others. So we might imagine, if we're thinking about activities in general life, that there would be different views. People would judge differently what they count as extremely high risk. But what about in the context of extreme prematurity? Where do we draw the line there? So here we are. If we have a baby being born extremely prematurely, what chance of survival without severe disability, if survival-focused care is provided, would correspond to an extremely high-risk scenario? In this case, you can only give one answer. So I want you to give the highest risk that you think would still be extremely high risk. So if you think 50-50 or anything below it would be extremely high risk, you would choose less than 50%. If you think anything more than 1% wouldn't be extremely high risk, then you would pick less than 1%, etc. So see where you would draw the line, below which point you would regard it as extremely high risk. Above this point would not be extremely high risk. Maybe a trickier question. People are a bit slower to respond than to which sports they regard as extremely high risk. And I meanly didn't give you an option of don't know for this one. But we've had 39 responses. Okay, so about a third of you have said less than 10% would be extremely high risk. Some of you had said less than 50%. Some have said less than 5%. So there's a spread of responses. Interesting. Good. So what do I mean by extremely high risk? What am I talking about? We're not focused on extremely high risk sport. What we're talking about is extremely high risk in the context of extremely preterm delivery. And the reason this particular set of words is featured in the BAPM framework, which I suspect many of you will be very familiar with. This was the revised framework for management, in particular decision-making at the time of birth for extremely preterm infants before 27 weeks of gestation. It came out in October 2019. For those of you who are somewhat less familiar with it, this was built on a general ethical framework that's been around for a long time, what many practitioners have referred to as the idea of a grey zone, the idea that there could be some extremely preterm infants for whom it would be permissible either to provide intensive care or to provide comfort-focused care, often aligned with a particular point of or points of gestation, below which, however, wasn't usually called this, but would correspond to the black zone, the area where it wouldn't be appropriate to embark on survival-focused care. That used to be 22 weeks or below. And above the grey zone, again, not usually called the white zone, but that was the implication, intensive care would usually be mandatory, would be provided. That used to be somewhere around 24, 25 weeks. So the new BAPM framework changed the color scheme. So instead of black, grey and white, changed it to something that matched traffic lights, red, orange, and red, amber, and green, and talked about, instead of particular days or weeks of gestation, risk. And the reason for changing it, I won't go into in huge amounts of detail, but broadly, the idea was what's ethically relevant is the chance for the baby, the risk for the baby. Therefore, that's what we should be basing these on. And the context, exactly the same as there was before, that there's some where the risk is so high, extremely high, that life-sustaining treatment should usually not be provided. There are others where there are risks, but they're more moderate and actually corresponding to our previous white zone, life-sustaining treatment should usually be provided. And in between, the the sort of practically tricky area where we might go either way. It's very important to have an in-depth conversation with parents, and it might be appropriate to provide either palliative management or what was called active management in that framework. And what we tried to do in developing that framework was to give people an idea about what level of risk would correspond to these different categories. And these numbers came from the survival without disability chances of infants born at the gestations that had previously corresponded to the black, white, and black, grey, and white zone. So they, but we also acknowledge that the challenge of drawing these statistical thresholds. But these in the BAPM framework were the sorts of numbers. Broadly, if your chance of surviving without severe disability was better than 50-50, that would correspond to the green zone, old white zone. If it was less than 10%, that was the, many of you gave that answer, that so less than 1 in 10 chance of surviving without severe disability, that would usually correspond to the extremely high risk category. And in between would be the amber zone. That was the idea that underlied the BAPM framework. As many of you will be familiar, there was an attempt to help people to understand how different risk factors might combine to influence risk. Not in a way that was entirely mathematical, because it's very difficult to do that. But if you took, for example, an infant at a particular gestation, thinking about how their other risk factors might make their risk higher or lower relative to average, was the idea behind the risk framework. So if we think about the infant that we talked about at the start of this talk, 22 weeks, at the beginning of the week, I didn't tell you about the estimated weight, but or indeed the fetal sex, but this was a normal estimated weight, around 500 grams, male infant, singleton, by their nature, had not had steroids in, I didn't tell you whether this was a hospital without a NICU or not. But if we have this combination of factors, even though there are some that are more favorable, others that are unfavorable, the idea in the framework was that this would correspond to extremely high risk. One thing that some of you may be aware of is that in the background there are a number of people, myself, I'm part of the wider group, who are undertaking a small revision of the BAPM framework, which will hopefully come out later in this year, should be out fairly soon for consultation. And one of the bits of feedback that we've tried to respond to in this revised framework is just to make the language super clear, particularly around this extremely high risk category. So this is what it said before, that life-sustaining treatment should usually not be provided. You should confirm the management with parents. And what in the new framework we've tried to say more clearly is that the appropriate thing to do if it's extremely high risk is to provide comfort-focused care. Comfort-focused care should be provided, and this should be explained to parents. And then it follows that what follows from that is that obstetric management focused on maternal well-being should be provided, and neonatal management focused on comfort. So the language in this draft, this revised framework, is aimed to be slightly clearer, particularly in these very difficult, extremely high risk scenarios. If you have feedback or ideas on that, you agree or disagree, when it comes out for consultation, please do feedback into that. I'm not going to say more about the revision in this particular webinar. So what I want to do is to focus now on how you should counsel in the context of a case like the one that we started with. The context for this is a framework for approaching antenatal counselling that I and my colleague Catherine Wood and others in Oxford have developed to help teach our colleagues, our trainees, and others who are involved in supporting women facing extremely preterm delivery, building on the BAPM framework, but giving people a structure for how to approach counselling. And this is the generic structure in the last framework and the last webinar, which focused on moderate and high risk, that talked about, particularly for the high risk, how to counsel parents where there is a key decision to be made between survival-focused care versus comfort-focused care. Here we're talking about extremely high risk, which, as I've identified, there isn't a key decision to be made about providing survival-focused care because that's not appropriate in the context of the extremely high risk, just as it wasn't appropriate in the past when babies were born at 22 weeks before we thought that was a reasonable option, just as it's not a question that we embark on if ladies present at 21 weeks gestation. If they have it, if when you take all the factors into consideration, it isn't extremely high risk, then the counselling becomes simpler because it's not about making key decisions. It's about communicating clearly and empathically the situation. So that's what we're going to focus on over the next 20 minutes or half an hour or so. So how do we do that? How do we translate that into practice? Well, one thing that I emphasize that's important and that's emphasized in the BAPM framework is that the first step is to assess the risk. That's something that you do before you go and talk to the lady. You need to go and assess all the information. As a number of you said, you needed more information in the scenario. One of the key things that I always emphasize to trainees that I personally do when I'm asked is to go and look at the early ultrasound report and confirm that the gestational age that you're being told is based on the best information that we have. Because clearly, sometimes even a few days might make a significant difference to how we'd approach counselling. So we need to work out, is this actually a high risk scenario, in which case we need to be contemplating serious discussions with the woman about what her and her partner's wishes would be for the child. Is there significant uncertainty about the risk? So if the risk is uncertain, if a number of the factors that, for example, are uncertain, that again might shift us into the orange zone rather than the red zone. But if there isn't uncertainty about it, or it isn't significant uncertainty about it, and there'll always be some uncertainty, then we need to clarify for ourselves what's the aim of the counselling that we're embarking upon. And as I've alluded already, in this situation, it's not about engaging in a decision-making process as much as it is about empathically explaining to the woman the situation that sadly she's in. Before embarking, going in, I often talk to trainees and say, before you do any procedure, you want to prepare yourself, prepare the equipment, prepare the patient. Here, and we can think of these conversations as like a procedure. We want to think about when is the right time to have this conversation. Clearly, it's important at a time when, if possible, the woman is there with support. So is there a partner who's able to be with her? Hopefully when before the delivery, so that this is able to inform the care of the baby, though again, it's not a situation of decision making. And hopefully that you've got the right people from the professional point of view who are able to come and talk to the woman. If she's presented in the middle of the night and delivery is not imminent, it might not be the right thing to do for the night juniors to be engaging in this conversation. If it's clearly a situation that can wait till morning, it would be important and better to wait till morning until there is somebody senior who can embark on this conversation. If it can't wait till morning, then the juniors, and some of you will be on this call, might wish to talk with their consultant about the situation, clarify the the nature of the risk, see if there's anybody who's available to support them in talking to the woman, and if not, to then embark on this conversation. Of course, that's what this webinar is hopefully supporting you and helping you to do. The principles that start at the beginning of this conversation is in fact the same, whatever the risk scenario. So it involves, as it would for, of course, many of our encounters with patients, introducing ourselves, clarifying the names of the woman and her partner. I always go into these conversations with a piece of paper and pen because I'm constitutionally incapable of remembering names if I haven't written them down on a piece of paper for longer than about a minute. But I'll also ask if they have a name for the baby and if they would like me to use that name. And of course, some families do and are happy. Others were not expecting to have their baby arrive for many months yet and have not arrived at a name, and that's absolutely fine too. It's super helpful and super important before embarking on discussions about the nature of the situation to understand what they've been told, what their understanding is of the situation, what their expectation is from you. That clearly frames how much work you're going to have to do in this conversation. It can be incredibly illuminating, and I almost always remember or try and remember to ask whether they know anybody who's been in a situation like this. If they've had a family member, personal friend, or they themselves have been in a similar situation before, that experience will enormously color their expectations of what's possible and what's going to happen. It's very helpful to ask them what's most important for them. So usually in this context, the women will be very aware that this baby is coming way, way too early. They may already have been told very grim and difficult things. It can be helpful to ask, for example, or to say, for example, we have some difficult things to talk about. You've already heard some difficult news. What's most important to you? And then I often say, and the flip side of what's important or what you're hoping for is what you're most afraid of. Understanding those things, both what the parents understand, what their priorities are, what their fears are, will then substantially shape what happens beyond, even in a context where there's not major decisions to be made, but even more so in the high-risk scenario, which again, we're not talking about as a main focus today. Only at that point would I start to explain things, tell them my understanding. And usually what I'll start with is what I think of as the big picture. So not necessarily granular details, but the understanding of the situation. I'm going to show you a video now of a recording that we made with some actors of exactly this sort of situation. This particular couple have very sadly lost a previous extremely preterm baby. They've also had a couple of babies previously who were born premature, but not this prematurely, and they're now facing delivery exactly like our scenario at the start of the 22nd week. I'm going to apologize in advance if the sound is slightly out of sync for you. Hopefully it will improve as the video goes on. My experience is that usually in this situation, when the stitch comes out, and that's paused, I'm not sure. When the stitch comes out, that usually baby will come quite quickly. So although we would hope that Elijah might stay inside, and there's a possibility of that, I'm afraid the most likely thing is that after the stitch is removed later today, which is the plan, that probably Elijah will come very soon after that.
But he could still be okay. Yeah. There's a chance he'll still.
Yeah.
I wish I could say that, but unfortunately he's too early. so sorry.
So, are you saying there's no way at all that he could survive?
So if by some chance after the stitch comes out he doesn't come and is able to stay inside for a bit longer,
Yeah.
and there isn't infection, then it would be possible for him to survive.
Okay.
However, if he does come today or tomorrow, right at the beginning of the 22nd week, I'm afraid that's just too early. Like your other baby who came at 19 weeks was too early.
Okay, there's still a chance. Okay. It's okay.
It's not easy to think about, but it might be helpful to talk about what would happen if he does come today or tomorrow.
Okay.
So unfortunately he would be too early, too small for our medicines and medical techniques, ventilators, to keep him with us. But there are things that we could do to care for him and to make sure that the time that you have with him is as good as it can be. So the aim of this video is not to show you something that's a script or that's perfect. I'm sure there are things that I could have improved in my particular interaction with these parents, but to give you an idea of how you might go about trying to approach counselling in this very difficult situation. So after giving the big picture, giving a chance for that to settle in, there is a question of providing further information about what baby might look like at delivery. Often parents are quite scared about what baby might look like, and it can be helpful to talk about the size of baby, colour of their skin, the fact that their eyes probably won't be open, the fact that they may breathe or make big breathing movements, or may indeed be born still, which is obviously a significant chance when they're born at this gestation. To talk a little bit about what comfort care would look like, I usually talk about the simple things that we can do to keep baby comfortable, keeping them close to the mother, keeping them warm, avoiding taking them, separating them from mother and parents, and that we have medicines that we could give baby by drops in the mouth if needed, but that in my experience it almost never is, and that babies are not uncomfortable. Babies born this early, if they are born alive, survive on average for 10 to 20 minutes, but sometimes longer, and sometimes their heart in particular may continue to beat and stay with us for longer than that. And it's important to talk about things that they might wish to do, that might be important for them to do to make the most of the short time that they're likely to have with their baby. Clearly, depending on the family, their expectations, their response to that is going to vary, and how you further navigate that is going to vary. We're going to talk about some challenging responses in just a second, but it's very important to try and be clear and consistent in explaining the situation, to address concerns, and of course to addressing what would happen if delivery doesn't happen, how the situation and indeed the risk may change if baby's able to stay inside somewhat longer. And then the last part of the conversation is to importantly validate the difficulty of the situation that they're in to provide reassurance that we are there, the wider team is there to support them, to summarize the key messages of that we've explained. For example, that very sadly, if baby is born today or tomorrow, sadly, he's not going to survive. But that if baby stays inside for a bit longer, that other things may be possible. And clearly to talk about further discussions in the event that baby doesn't deliver. Providing some written information. We have some locally based on the BAPM framework information that we can provide to families in the context of these extremely high-risk deliveries. So that's the basic approach to communication in the context of extremely high risk. But of course, and I suspect some of you will have anticipated, there may be challenges. So let's talk about some of these. And I've got another short video for you to show you how you might address some of these challenges if they come up.
The woman that I met though, and her baby, that he was on oxygen for a long time, but he did survive. There's no chance of that for
maybe a chance, a small chance.
So if babies are born later, even as late as the end of the 22nd week, if the mothers have had a chance to have some steroid medicines, you probably had them for your daughters, that can improve their chances. Still really high risk, and actually most babies born even at that stage still die. But I'm afraid for Elijah, not even that chance is something that we are able to offer him.
So families might talk specifically about hope, in which case I might talk to them as you saw me there, saying that if he's able to stay inside, if gestation is able to be prolonged, that things may be different, that it may be possible to provide intensive care to keep him alive and even hope of surviving. If they ask if there isn't anything that you can do, I think it's helpful to talk about the things that we can do to make sure that baby is comfortable and to maximize the quality of the time that they have with baby. If they beg or plead for us to do something, sometimes I use the language of wishing. So you might have heard in the first video, I said at one point, I wish that we were able to do something different, or I wish that the situation was different. And my experience, the language of wishing is very powerful. It expresses what they hope for, what we wish were the case, but also is not the case. I wish we weren't in this situation or having this conversation. I wish there were something that I could do differently. They might talk, as you saw that family talk about their experience of somebody else who had a baby at 22 weeks, etc. And it can be helpful to say, look, in other situations where things are different, where babies are slightly further on, things may be different, other things may be possible. I'm afraid, though, for your baby, that's not the case. There may be more challenges. So we talked already about uncertainty. Clearly, if there's uncertainty about gestational age, then it's not going to be possible or appropriate to take this as clear-cut approach to thinking that this is an extremely high-risk scenario. If there's a possibility that actually the baby's gestation is longer, then indeed we would then be embarking on something that looks more like a high-risk scenario. There are situations where decisions might need to be made very rapidly before it's been even possible to have this conversation with women. And then you and your teams are going to have to decide whether in that context the appropriate thing to do, as it might be, is to just provide survival focused care. Clearly, if the woman's just walked in at 20 weeks or 21 weeks gestation, even if nobody's had a chance to sit down and talk with her, that's what you would do. And if this is clearly an extremely high risk scenario, then that is the appropriate management. But of course, sometimes by the time you have got there, somebody else who got there quickly and perhaps didn't have all the information, was uncertain about what the right thing to do, may already have embarked on providing survival focused care. And of course, in the context of uncertainty, that is the right thing to do. If you're not sure, you err on the side of providing treatment which you can stop rather than withholding treatment which you can't undo. So if decisions have already been made, survival focused care has already been provided, then there is a really important but very challenging situation of then assessing what is the right thing to do next. And sometimes what the right thing to do next is to acknowledge that actually this is an extremely high risk scenario, and if we had all the information, it would not have been appropriate to embark on survival focused care. And that actually the right thing to do, although we have started, is now to stop. For transport teams, that might mean that a baby that has had survival focused care initiated, though in fact, in reflection, that perhaps wasn't the right decision, wouldn't have been advised, will then need to talk with the local team about how to manage that, whether it is appropriate and possible to support providing comfort focused care in the local unit, though I fully acknowledge that that's very difficult. It would have been better to not have embarked on treatment in this context, because that, given the risk framework, was the right decision. Sometimes if things have been done that would not have been done, just as if somebody's continued CPR for 30 minutes in the context of a term infant and then a heart rate has returned and everybody thinks, oh dear, now what do we do? Sometimes we're in a situation where we might not have wished to be, and we have to work out what to do next. If there's disagreement, ongoing disagreement with the parents, it may be necessary, may be important to get a second opinion. If you're in a level 2, it may be helpful to speak on the phone with the level 3 consultants and to seek their advice about how to manage this. If you're in a level 3, it may be important to talk with the neonatal consultants or with other neonatal consultants to assess whether this is a situation of uncertainty or whether actually it's very clear that this is an extremely high risk scenario. What about some other scenarios? I've got some more poll questions for you. You've had a call from delivery suite. A 29-week lady has come in with contractions. Her baby was diagnosed with renal agenesis and has had anhydramnios since 18 weeks. Please, can you come and talk to her? So what do you think? Is this extremely high risk? Or you don't think it's extremely high risk, you think it's high risk, the equivalent of 23 weeks? Is this moderate risk? Does the risk framework not apply, or maybe you don't know? A few responses coming in, people getting their phones out again. I've got a couple more coming up straight away if you're still fiddling with the technology. Okay, so a number of you think this is extremely high risk. Some of you think that the risk framework doesn't apply. Some think that maybe this is a high risk. Somebody even thought this was a moderate risk. Okay, what about this case? So this is a lady who's presented at 23 weeks. There's an ultrasound which estimates the fetal weight at 305 grams, extremely growth restricted baby. She's in preterm labour, expected to deliver. Is this extremely high risk? Or is it high risk or moderate risk, or maybe you don't know? Let's see. Okay, so we've got more agreement here that this is extremely high risk, though some of you thought that this is in the high risk category. Different scenario for you. A 25-week infant with hypoplastic left heart syndrome. She's in delivery suite. She's contracting. It appears that she's going to deliver. Is this extremely high risk? Yes, no, no, this is high risk, no, this is moderate risk, or the framework doesn't apply. So again, there's a more of you think that this is extremely high risk, but some of you think that this is high risk, and some others think that the risk framework doesn't apply. Okay, so I haven't got a slide on this, but I'll tell you my thoughts, my response to these questions. So the idea of the risk framework is that numbers of weeks is not the relevant thing. The justification, the ethical justification for our decisions is based on the outlook for the baby and the burdens of treatment that would be required to keep them alive. So on the basis of the ethical principles that apply in the extremely preterm framework, a baby who presents with anhydramnios and confirmed bilateral renal agenesis would have unquestionably a less than 10% chance of survival without severe disability. Indeed, very sadly, it would be a lot less than 10% chance of survival without severe disability. So in that context, the appropriate management would be to provide comfort care. Likewise, the 23-week and the 25-week infants, so that although the BAPM framework wasn't designed to apply outside extremely preterm infants, maybe that's why some of you said that the risk framework didn't apply, the principles can certainly be applied to infants born at 29, 30 or 31 weeks, etc. And as emphasized, and as indeed many of you have emphasized, it's not just gestation based. It's supposed to take in these other factors. So you can have a baby that's born at 23 weeks, which we might normally think is in the high risk category, but who's actually extremely high risk because of their gestation. Or a baby who's born at 25 weeks, which would normally be in a moderate risk category, but who has hypoplastic left heart. And as a consequence, their chance of survival without severe disability is clearly less than 10%, in which case the same ethical approach would apply. Here's a different challenge, and this was inspired by some questions that came out of the last webinar. Some of you might have been thinking of this already. What if the lady who's presented at 25 weeks, her baby doesn't have hypoplastic left heart, actually doesn't have other medical conditions at all? She's an obstetric registrar, which is obviously not relevant to the risk, but is relevant to her request. And she's expressed that she does not wish for resuscitation at birth. Please, can you come and talk to her? What risk category does this fall into? You're getting very good at answering these questions now. The numbers racing up very quickly. Okay, so a number of you have said that this is moderate risk. As we've said before, moderate risk implies that normally survival-focused care is the appropriate management and would be provided. Some of you have indicated that this would be high risk, and maybe that's because you're thinking that in this context that it would be important to consider the option of providing comfort care. Some of you have said correctly that you need more information because I didn't tell you what the estimated fetal weight was, whether this lady has had steroids, where she's delivering, etc. We haven't got all the information here, so we do need to get some more information. If we put the information that we have, on the information that we have, this is likely to be a moderate risk scenario, but of course we would want to know that other information. And if this is moderate risk, then the appropriate management is to provide survival-focused care. So maybe the distractor here is that we've been told that she doesn't wish for resuscitation, but her wishes, which of course are going to be important to address, are not relevant to assessing the risk. The risk is a function of the prognosis for the baby. And the question is, on the basis of that risk, what's the appropriate thing to do? And for the average baby born at 25 weeks, the appropriate thing to do is to provide survival-focused care and to then, in the context of counselling, to explain that management to parents. But not to be offering the option of providing comfort-focused care, because the risk is sufficiently favourable that wouldn't be ethically appropriate. That's what the BAPM framework implies. So how then do we practically respond to these really, really challenging, though rare situations where parents request non-intervention in a situation that wouldn't usually be provided? Well, we need to identify the relevant facts. We need to identify what the parents, the mother's understanding is, and how that may differ from our own. So is the reason that this obstetric registrar is not wishing for resuscitation because she's had very bad experiences? Maybe she thinks the outcome is much worse than neonatologists in the current era would think is expected for her baby. Secondly, we need to understand what her values are, what is the reason for her request, in particular to identify and address fear. So it might well be a fear of overwhelming disability, a long period of intensive care, very substantial burden on her family. We need to identify, talk about how neonatal teams would be able to support and address that. In the context, as it sometimes is in these requests, where what families are really worried about is what they see as the worst possible outcome is if baby has very severe long-standing disabilities. It can be important to talk about what would happen if baby comes to the intensive care unit and has severe complications. For example, has severe intraventricular hemorrhage, has severe sepsis, isn't responding to treatment, and to talk about how embarking on treatment doesn't mean that we are committed to continuing it if the outlook for baby looks very worrying. And just as I alluded earlier on, if there is persisting disagreement once you've done that, then it, of course, may be important to seek a second opinion from a colleague to ensure that your assessment of the risk is confirmed by others, and that others agree that it wouldn't actually be appropriate to be offering comfort-focused care in the context of a 25-weeker without other risk factors. Okay, we have just about finished, and then I'll try and address questions from the Q&A. I have one more scenario, one more question for you. This is exactly the same as the scenario that we offered at the start. A lady at 22 plus 1 weeks is coming with premature rupture of the membranes. She's had a cervical suture. Please, can you come and talk to her? And this is a repeat of the question that I asked at the start. You've got to the end of this scenario. How comfortable now would you be providing counselling in this situation? I'm hoping that you're more comfortable than you were at the start, but of course you should answer honestly. If you feel more uncomfortable, I'll go away and scratch my head and try and think about what to do better next week when I do this seminar again. I'm very pleased to see that the level of comfort among you for addressing this seems to have gone up relative to the beginning of the talk. That's very comforting for me too. What we've done in this webinar, just to summarize, is talked about what we mean by extremely high risk in the context of babies being born very early. We've talked about a general approach to extremely high risk counselling, clarifying what the purpose is and what are and how to go about that. And we've talked, as mentioned already, that's the same framework, though of course modified to the extremely high risk context that we have developed as part of a larger full day training program that we have run several times. There will be further in-person sessions that we're going to run later in the year. I can't give you the information about them just yet because we haven't opened registration for them, but if you've registered for this webinar, you will get sent the details about those. And then we've talked about how to address some of the challenging questions and scenarios, but I'm sure you've got more tricky questions for me in the Q&A, which I will try and address over the next half an hour or so. Thank you very much.
Dominic, thank you very much. There aren't any questions in the Q&A at the moment, so while we wait for some to come in, if there are particular areas that you wanted to just maybe focus on, or please carry on, and I'll keep an eye on the Q&A. There was a question, I think you've sort of covered it on the slides, on the first webinar relating to the legalities around comfort care for 25, 26 week gestations where parents choose that option or ask for that option.
So I talked earlier about how we ought to approach those requests. So I've talked in the context of ethics rather than law. I think it's useful just to I mean, just as a disclaimer, I'm not a lawyer. I know a bit about the law in this area, but I'm not really equipped to provide you with legal advice. There is no law that relates to resuscitation decisions for newborn infants of any gestation. So how would the law approach it? Well, the legal principle is that we ought to be acting in the best interests of infants. And of course, how would the court approach thinking about would it be in the best interest? Well, they would look at what normally happens and what professional guidance says. So if professional guidance indicates that it would normally be conceived as in the best interests of a baby born at 25 weeks without other risk factors, etc., to provide survival-focused care, and you decided not to, then you would be deviating from normal standard practice. Now, you might have some very good reasons that perhaps I'm not aware of for making such a decision. Clearly, if there were other risk factors such that this baby at 25 weeks was actually high risk, then that would be very good reasons for making a different decision. If the baby had hypoplastic left heart, was extremely growth restricted. If you don't have such risk-based reasons, then it's more challenging to defend. But there isn't any case law or other legal precedent for such a decision.
Thank you, Dominic. I'm going to take a question from Kristen, and she's asking, are obstetricians on board asking the neonatal team to counsel and give information, or at less than 23 weeks? Are obstetricians making assumptions when parents might like options to be given more information?
So I'm going to answer this in a slightly indirect way. There are a number of you here who are not neonatologists, but obstetricians, fetal medicine, or other midwives. I've talked about how a neonatologist, I'm very familiar with how a neonatologist would approach this, but clearly these conversations are not just had by neonatologists, they're also had by obstetricians and midwives talking to women. One of the reasons why we think it's very important that this training is opened up to other professionals is it's very important that we have a shared understanding about what's the right way to approach these conversations, what's possible, and of course what our colleagues are going to say. If I say something and my colleague is saying something different, that's going to be very confusing for parents and potentially likely to make things difficult for me or them, and certainly for the parents. So one thing that is very important is for us to all be working together. And one of the ways that we can do that is by having these conversations together. So I didn't talk about it explicitly, but I should have probably. When I talked about who should be doing this counselling, I suggested that it should be somebody senior. So that will often mean a neonatal consultant rather than an SHO or registrar. But it might well involve having joint counselling together with an obstetrician, obstetric registrar, and if possible with midwives. And with the midwives is super important because, of course, they're often going to be the ones providing ongoing support for women and their partners. So that's, I think, the answer to how do we ensure that expectations, communication are aligned. Well, one is to be going to the same training, coming along to the same courses, talking to each other about how we understand these scenarios, what we understand the risk assessment to be and what that means. And secondly, where possible, and it's not always possible in the difficult and busy world of a delivery suite, but where possible, for us to be supporting these families together. And I've certainly found it very helpful on a number of occasions to see these women together with our obstetric team.
Thank you, Dominic. I think there was a question on the previous webinar about that, so it's helpful that you've had practical experience of being able to counsel with your professional colleagues. The question from Richard, which says, how important is transfer to a NICU from an LNU, even if the situation is extremely high risk? So even if at the presenting time, the best option is comfort care, even if it is to just provide comfort care in the NICU, would the risk change significantly to high risk by just being in an ICU?
So if I flip, so it's a really good question. So if I flip the question around, there are certainly situations where if this lady delivers in a local neonatal unit rather than a unit with a co-located NICU, it would be extremely high risk. But if she's able to deliver in a centre with a NICU, it would then be in the high risk category. So I'm thinking in particular of women later in the 22nd week who potentially have had steroids already, haven't got additional risk factors. Those babies, if they are born in units without co-located NICU and are then going to have to be transferred, as was discussed in some more detail at the BAPM webinar on this topic earlier this year, those infants would be extremely high risk, and very sadly, it wouldn't be appropriate to be embarking on survival focused care, even though if they'd managed to get to a tertiary NICU centre, that would be different. So the question about should these women be transferred depends on the details. So in some situations, transfer is not going to change the risk category, therefore it's not going to change what's appropriate to do. And actually transfer itself not only involves very significant risk for resources, transport teams, etc., short delivery suite cots, which are in short supply in tertiary centres, but of course separates the woman from her support network. If it's not going to change the care that's offered, then it would be inappropriate to do so. So, for example, the lady who's presented at 29 weeks with renal agenesis, transferring her to a level 3 centre is not going to change what's appropriate to offer for that baby. Likewise, the 25-week with hypoplastic left heart isn't actually going to change what's possible if that lady is transferred. The lady who's presented at 22 plus 1 weeks, if she's transferred today, it's not going to change what's possible for that baby today or tomorrow. But if baby doesn't deliver imminently, then it may well be appropriate over the next couple of days to transfer. And if she can get even a couple of days further on and has had steroids and she would wish for it, then it may be appropriate to offer survival focused care. So that's the slightly long-winded and more complicated answer to a very tricky question.
Thank you, Dominic. So let's take a question from Annabelle. The parents are included in these discussions. What happens in the scenario where the parents don't want you to resuscitate, but there is moderate risk to the preterm? The neonate has rights once born, So where do we stand as health professionals, especially if the parents have risk assessed what would suit their family dynamics with a preterm baby?
Thanks, Annabelle. So just as I suggested earlier, if we think that it's in the best interests of the baby to provide treatment, then that's what our professional, ethical and legal obligation is. So just as if we had a baby born with Down syndrome, it would be our obligation to provide survival focused care, even if parents didn't wish for that. Now, clearly, the decisions that they are legally and ethically able to make before birth are then quite different to the decisions that they can make after the baby is born. And so that sometimes is hard for them to understand. Sometimes it's hard for our peers to understand because it seems contradictory. There are ethical explanations of how these decisions might or could change so quickly between before and after birth. But in terms of the law, it's very clear we have obligations to take into account the best interests of the baby once the baby's born. That, of course, doesn't mandate, you've already heard me talking at length about situations, it doesn't mandate us providing survival focused care for any baby born alive. If the risk is extremely high or high, it would be very appropriate to provide comfort focused care in a high risk scenario, assuming parents wish. But if the risk is better than that, if the outlook for the baby is better such that we think it's in the baby's best interest to provide survival focused care, we would struggle to defend providing comfort focused care instead, even if that's what the parents are wishing for. And then, as I explained, the challenge for us is to empathically explore why the parents are requesting something that is very uncommon, commonly requested in this community. What is it that they're afraid of? What are their understandings? And to empathically explain what it is that we can and can't do.
Thank you. It's a comment, but I think it's an acute one. It's from Chloe in Dartford and Gravesend, I think. And she's saying that we're not a NICU. I have had 2 mothers of very high-risk infants self-discharge and walk into a hospital with a NICU to give their baby a chance. One sadly didn't make it. One did and was repatriated to prepare for home. Baby was unable to feed orally, on oxygen, and with vision and hearing problems. Mother still stands by her decision and thinks we should always resuscitate. Chloe looks forward to the revised bathroom guidance, which makes it clearer when comfort-based care is best prepared when parents may not agree.
Thanks, Chloe. So mothers have important rights to make decisions for themselves and about their body, and they might make decisions that we personally wouldn't agree with, but of course there are very important ethical and legal limits to what we can do to an adult with capacity against their wishes. So if a woman decides to discharge herself because she doesn't wish for her baby to be treated like the 25-week infant, then we wouldn't be able to keep her in hospital against her wishes. Nor, of course, in other scenarios, would we be able to do a cesarean section against her wishes, even if we thought that was in the baby's best interests. In the opposite direction, of course, if a mother takes herself to another hospital and requests intervention for her baby in a context where the risk is thought to be extremely high, then those in that hospital are going to have to assess what the risk is and what it would be appropriate to offer. We've talked already about situations where parents might disagree with the professionals about just providing comfort-focused care in the context of extremely high risk and how to manage that. For example, seeking second opinions, ensuring that all the facts are clear. The revised BAPM framework, as you've pointed to, Chloe, hopefully will make it clearer that the appropriate thing to do in the context of extremely high risk is to provide comfort-focused care. I said before, just comfort-focused care, but I don't think it's just. I think it is the right thing to do in that circumstance.
So Dominic, from Rupali, how do you respond in an extremely high-risk situation when families say they have seen online with survival rates of 22 weeks for 1 in 3, and that they want that chance for their baby, whatever the risk of long-term issues? They might have seen stories of miracle babies online.
So I think it's certainly not unique to this situation that parents will find online information and might hope and try to apply that to their baby. And of course, just as in those other cases where we encounter that for in the babies in our care, it's important to listen to those parents, to see what information they have, and to help them to understand how that does or doesn't apply to their baby. What the BAPA approach makes very clear is that the risk for individual babies depends on their individual circumstances. And of course, for babies born at 22 weeks, there's a variation in their risk depending on their other factors. The revised BAPA framework includes some more up-to-date data from the UK about the survival of babies born at 22 weeks who receive survival-focused care. That's based on figures which a number of you may have seen, some of the published data, where the outcome for the somewhat less selective cohort of infants in the last few years who've been treated, including some babies at 22 weeks with extra risk factors, that actually the survival rate for them overall is more like 1 in 5 than 1 in 3. That's not any longer the average survival for babies at that gestation. But for an individual baby, like this baby being born at 22 weeks, we have to take into account their individual circumstances. And so the reason for thinking this baby is extremely high risk is because when we do that, actually their chance of surviving is much, much lower than that.
So there's a question from colleagues in Dorset. Is it appropriate to provide a leaflet for parents regarding the survival rate, which is mentioned in the BAPA framework for extreme preterm?
So I think it's very important to contextualize the information that we give to parents to their individual circumstance. So the infographic, which talks about average survival at a particular gestation, also says at the bottom that the chances for individual babies may be higher or lower than this. So when we give parents information, we should contextualize for them how their baby situation might be different from average. For babies who are being born in the context of extremely high risk, the information that we provide is specific to babies in that situation. So it doesn't talk about what survival-focused care would look like and the difficult choices they might be making, because of course that's not the situation that they're in. I think it's important for us to help parents to understand the information that they have, whether that information is from online, it's in paper. The information on paper is clearly accurate on average for groups of babies, but we're not talking about average babies. We're talking about their specific situation.
So one from Emma McDermott. She's interested in understanding who provides counselling to mothers at level 2 units in our network in Thames Valley and Oxford. Is there support from level 3 units? Speaking to parents, they feel that the information provided by level 3 neonatologists differs greatly and is needed to help in their decision making. So the disparity between quality of counselling, I guess.
Well, I guess one of the contexts for this, for the course that we've developed for this webinar, is to help support our colleagues locally, regionally, and nationally to improve their confidence in providing this counselling, improving their skills in counselling, and hopefully improve some of the consistency in how they approach that and maybe the information that they give. It is challenging, of course, that different doctors might say different things. That's not unique to extreme prematurity. We do need to try and be consistent in the information that we provide Specifically, when a lady presents to a level 2 unit, although the level 3 consultants might have more experience and might be able to provide more detail in their counselling, it's very important that she gets to talk to somebody at the level 2 unit, apart from anything else, because there may well be a very important decision about, does she need to be transferred to a level 3 centre? And if it's clear that she actually wouldn't wish for survival focused care in the context of high risk, then actually it's very important that she doesn't get transferred. So I've had the experience, others may have others working in level 3 centres may have this experience of seeing a lady who's been transferred to our centre at extremely preterm gestation, high risk. But when I've sat down and talked with her, actually she didn't wish for survival focused care. Now, she's then been transferred unnecessarily. She'd also had magnesium unnecessarily, which made her feel absolutely dreadful, and of course is associated with risks. She'd had steroids unnecessarily, which is extremely painful and is associated with risk. So there is we absolutely need to try and get those women who wish for survival focused care and for whom it's appropriate quickly to the level 3 centres. That's very important. But we also need to make sure that we don't transfer women unnecessarily.
Thank you, Dominic. So Sarah from Friendly Health, it's a very specific question. Do you ever use the navy pink BAPM infographic on outcomes according to gestational age? So it quotes at 22 weeks, 7 in 10 babies die and 1 in 3 have severe disability. But it feels very inappropriate to just risk assess based on gestational age alone. How do you navigate between this and the BAPM traffic light categories? So, for example, go ahead.
So the short answer is that the BAPM framework both aims to give people an idea of the starting point, the average outcome at different gestations, but also how they need to adjust that. Specifically, I mean, many of you will be very aware of this. I'm sure a number of you have used this. I very often use the NICHD online calculator. If you Google NICHD calculator, that allows you to input some of the relevant risk factors other than gestational age. So you can indicate, for example, that the baby is male and a multiple and hasn't had steroids, as well as being 24 weeks. Have a look at that calculator if you haven't already and see how that modifies the chances. I think that then helps to give us an idea about what the relative risk for that baby is relative to average and whether they ought actually to fit into a high risk or moderate or extremely high risk category. What I wouldn't use that calculator is as a way to work out what number to quote to the women. So if you use that calculator, maybe I'll see if I can pull it up in the background and show you what that looks like. If you use that calculator and it tells you that there's a 27% chance of the baby surviving, and if the baby survives, there's a 13% chance of this and a 14% chance of that. I wouldn't use that to then go and talk to the woman and say, actually, there's a 27% chance of surviving, and there's a 13, if the baby survives, there's a 13% chance of this and a 53% chance of that. Those sorts of statistics, even if they're accurate as they can be, are usually worse than useless. And I'm being deliberately provocative. In other talks that I give about how should we approach counselling, I make the point that our parents are not Vulcans. So those of you of a certain age will recognise that I'm referring to Mr. Spock from Star Trek, who as the kind of ultimate in logic always talks about these percentage risks and is making decisions based on those sorts of percentage chances. But that's not how our mothers are making decisions. For them to know that there's a 27% chance of this and a 13% chance of that and a 53% chance of something else is not how they make decisions. Apart from the fact that many in our community struggle with statistical literacy, let alone health professionals, sometimes struggling with how to interpret those numbers. It can be super important to know that their baby has a 1 in 4 or a 1 in 5, to understand that out of every 5 babies born at this gestation, that 1 would survive and 4 would not, or whatever the relevant. But the detailed percentage figures that you'll get from the NICHD, I wouldn't be tempted to start quoting those figures, because I don't think those helpful, and I think they're it's very easy to overwhelm with numbers.
Dominic, Catherine mentioned the NICHD calculator. She said something about the data being American, and she had some caution around it. Is that?
So let me just show you for people who have who are interested. I'll just show you what it looks like. Let me see if I can. There we are. I'm hoping that you can see that. So this is what the tool looks like. A number of you will have seen it, and others have probably Googled it in the background. But the sort of information that this gives is based on babies who are admitted to specific US hospitals in the US between 2006 and 2012. So it's clearly going to be influenced by the location, the time, the point in time. Nevertheless, so I think the most useful way of using this is to understand how the specific risk factors for an individual baby might influence in a positive or a negative direction, rather than the absolute numbers. Having said that, the sorts of numbers that you get from this are reasonably consistent with the sorts of outcomes that have been seen in the UK specific outcomes. So I think that they're a pretty good guide, though. It'd be even better, of course, if we had a UK model of this, but at the present time we don't. And it doesn't include some of the risk factors that are important. It doesn't enable you to point to the start or the end of the week, or whether the baby's being born in a level 2 or level 3 centre, for example.
Dominic, there's one final, it's more of a comment, I think, than a question, to be honest. And it's from Tracy in Ashford and St. Peter's. And her comment is that often our LNUs want to transfer to a level 3 hospital once the woman gets to 22 weeks. And parents often perceive that this means they will be offered survival focused care. And Tracy is just commenting that we need more joined up counselling for these cases. Yeah, so I think it's for the reasons that I've alluded to already, it may not be the right thing to transfer if it's not going to change the care that's able to be offered or provided. So our own local approach would be very focused on at what point would it be appropriate in the context of the individual lady to be offering, to be thinking that they're in the high risk category, and then therefore to be offering the option of survival focused care. So there's two questions. One is, what's the risk for this lady? And then also, what would her wishes be? So if she's just 22 weeks, it's highly likely that she would still be extremely high risky, even if she walked through the door of a level 3 unit. That would certainly be my interpretation. Of course, you'd want to look and make sure, check the other relevant risk factors, and you'd want to check her dates. I alluded already to the importance of making sure those numbers are correct. But secondly, of course, you do need to assess her wishes. So if she were 22 plus 3, 22 plus 4, but actually it's clear that she would not wish for survival focused care, then it's very important not to transfer her unnecessarily. Dominic, I think you've covered all of the questions brilliantly. Thank you so very much. And thanks to the participants today for your attention and for some fantastic questions.